Welcome to Erin's webinar, Contrast-Induced Nephropathy, Recognition and Prevention. Dr. Wolfgang Weiss is our physician this evening. He's board certified in internal medicine and nephrology, specializing in acute and chronic renal failure. He's practiced for over 28 years. He's currently the associate professor at the University of Vermont College of Medicine. And participants are going to receive an email tomorrow or so for the webinar link to complete your evaluation for this webinar. Once you've completed the evaluation, you'll be able to download your certificate at that point. As far as a technical announcement, the live presentation, you'll need to have a flash player in order to view the webinar. And this webinar is not visible on an iPad or iPhone live. It is available, though, for on-demand viewing. So we're recording tonight. It will be available for the future for on-demand. We'll house it in a private YouTube channel that will be able to be viewed with the iPad and iPhone in the future. Participants for this live webinar will also have access to that on-demand version. Questions submitted during the presentation are simple. Just type in your question in the chat box, and Dr. Weiss will be able to answer your questions. And the planning committee and the speaker have no disclosures at this time. So Dr. Weiss, please proceed.
Yeah, thank you very much, and welcome everybody to the webinar. I've done that once over in Germany, where I give some talks occasionally. So this is it's a premiere, so to speak, for me. At any rate, the topic today, contrast-induced nephropathy, is quite common, at least in my practice, and I just want to educate you a little bit about the risk and prevention. And radio contrast has potentially lots of adverse reaction. There's anaphylactoid reactions like allergies, and then so-called chemotoxic reaction, and the contrast-induced nephropathy is one of them. Otherwise, you see here muscle weakness in people who have myasthenia gravis, people who have pheochromocytoma, a rare form of high blood pressure. They can have a hypertensive crisis when they get exposed to contrast material. And you may know that there is increased risk of lactic acidosis in patients who take metformin. Therefore, it's recommended to stop this drug about 2 days prior to contrast, although the evidence, if you look at it, is not all that great in terms of what the real risk is, but that's what every society recommends. So today I'm going to talk about these topics here. First, risk factors, so the question, who is at risk? Secondly, there's a variety of contrast agents, and there's some more dangerous than other, than the pathophysiology of contrast-induced nephropathy. What's the definition and diagnosis of it? And most important, what is the role of prophylactic intervention? If you forget everything about this talk, one thing you should remember. In contrast-induced nephropathy, only prevention is helpful. If you have given the dye and induced contrast-induced nephropathy, there is no specific treatment available that will improve the outcome. Then obviously conclusion and recommendation, and then a short topic that we always get asked, what about contrast media in patients who are on dialysis already? All right, so this is a very old slide, some 20 years ago, where researchers looked at who is at risk, and if you can see it here, independent predictors of the development of contrast-induced nephropathy. And here you see the so-called odds ratio, how likely is it to develop it if you have, for example, a creatinine of 2 to 2.9 milligram per deciliter. Well, your risk compared to an individual who has normal kidney function, meaning creatinine about 1, is at least 7-fold higher. If the creatinine is above 3, so getting towards, fairly advanced kidney failure, the risk is 12 times higher. Now, diabetics, even if their creatinine is pretty normal, have a slightly increased risk. Often these individuals have diabetic kidney disease with proteinuria. Patients who are in shock have myocardial infarction at higher risk. And then obviously individuals who have overall chronic renal insufficiency, their risk is quite increased. So the first kind of topic is the risk of contrast-induced nephropathy is primarily predicted by pre-existing chronic kidney disease. That's why it is prudent if you expose an individual to contrast that you know what is their kidney function, and that's easily measured with a serum creatinine. How about the various contrast agents? So the contrast agents have gone from very high osmolar solutions here in the 1950s to less and less or lower osmotic solution, and the most that's used now nowadays are these non-ionic dimer that are listed here at the bottom. And if you look at the osmolality here on the left on the x-axis, you see the old ones were very high, over 2,000 milliosmol per kilo. Our blood osmolality or serum osmolality is about 285. You can see that these newer ones, these are called isoosmol, and the ones that are here in the 500, 800 milliosmol range are called low osmolality contrast material. Also, some of them have higher viscosity. They're thicker, like these two here, and whether or not that plays a role is not clear. There's some research that indicates that it's more important than osmolality, maybe viscosity. So the current contrast agents that we're using are either low or isoosmolar in nature. How about the pathophysiology of contrast-induced nephropathy? Obviously, there are two issues. There is the patient-related issue, and I've talked about previously who is at risk, individuals who already have some kidney failure, patients who are somewhat volume depleted or have congestive heart failure, because in congestive heart failure, the kidneys get less blood than they usually do compared to individuals who have normal pump function and don't have congestive heart failure. And then there's the contrast media. The contrast media is given, as you well know, intravenous or intra-arterial, and gets fairly fast into the kidney. It is filtered easily by the kidney. And then it appears what's called the proximal tubules. The proximal tubule is the site where most of the filtered substances, water, salt, glucose, phosphorus, many other things, are reabsorbed, okay? And especially if then patients are volume contracted, the proximal tubules works even more to especially retain salt and water to avoid further volume depletion. That's why, we'll talk about in a minute, that's why there is a lot of toxicity, because the dye essentially follows salt in the proximal tubules and are taken up there. If you give dye in animals, like rats have been shown, you induce vasoconstriction. All right, so the kidneys, in that sense, get already less blood, okay? When that's given, that lasts several minutes after being given, and then it affects the red cell membrane as well. So all of these factors then lead to contrast-induced acute kidney failure. And that's here depicted again. So here's the glomerulus, that's the filter apparatus. Each kidney has about 1 million of them. The dye is filtered, appears here, and then is reabsorbed in these sites where it says direct tubular toxicity. In addition, there is this vasoconstriction, so less blood in the kidneys, especially down in these deeper areas. is already very, doesn't have much oxygen. And now you induce vasoconstriction and you induce what's called oxidative stress. You produce or impair the production of NO, nitric oxide, which is a vasodilator, which tries to counteract the vasoconstriction. And all this leads to further decline in kidney function. So the pathophysiology of contrast-induced nephropathy includes vasoconstriction due to decreased nitric oxide production, medullary hypoxia, and direct tubal toxicity. It's not clear whether one or other of these issues plays more important role than others. Okay, how do we recognize that an individual who has received contrast has contrast-induced nephropathy? Well, you need to obviously know what their baseline creatinine is. And then within 48 hours, the creatinine should not go up more than 25%. So say the baseline creatinine is 2. If it goes up to 2.8, that will fill the criteria, or some people say more than 0.5 milligram per deciliter if the creatinine is below 2. Or that doesn't happen very often if their patients have oliguria, meaning their urine output is below 1/2 liter per 24 hours. So if you look at the course of this contrast-induced nephropathy, what you can see is that at time 0, there's contrast in exposure. You have a certain baseline creatinine, which is here on the x-axis. And then the creatinine, the marker for kidney function, goes up. Usually peaks at 4 or 5 days if you follow them, especially individuals who are hospitalized. And then over, a week or 2, it falls down to, and it's actually fairly symmetric, as you can see. So you can actually predict as soon as it peaks. I often can say, well, in about 6 days, hopefully, the patient's creatinine is back to normal. And patients don't have any pain. Okay, kidney failure is not associated with any subjective symptoms. Rarely, if ever, do they make, they've noticed that they make less urine output. For the most part, it's asymptomatic. Now, there's another condition that's called atherosclerotic renal or kidney disease that can occur in individuals who are exposed to arterial contrast. For example, cardiac catheterization or angiograms. And this course is a little kind of slower. It starts later. It's a little kind of staggering. And that's induced by the emboli to the kidneys. Remember when the cardiologist does a cardiac catheterization, they go through the femoral artery to the heart, and they go through the aorta, and the aorta in these individuals often very arteriosclerotic. There are plaques at the wall of the aorta. If you watch that several times, you see that it's sometimes not that easy to advance the catheter toward the heart. And so they may chop off or loosen some plaques in the aorta. And if the plaque is above the kidney arteries and loosens, then they can end up in the kidney, so they can end up in the toes. That's called blue toe syndrome. Those are all signs of emboli. And it's not the embolus per se that causes kidney failure, but rather the inflammation that's caused by the emboli. And short of a kidney biopsy and knowing about this condition, you can't really diagnose it. Sometimes I see patients that are 3 or 4 days after cardiac catheterization, they get short of breath, to their cardiologist, and they say, well, your heart is fine, but your creatinine is now 4 and it used to be 1.5. And that's most likely atherosclerotic kidney disease. Remember that occurs only in arterial in arteriograms. Okay. So what's the big deal about contrast-induced nephropathy? You know, creatinine goes up, comes down, and that's indeed the case mostly. But here's a classic study, published some 20 years ago from researchers at Yale, and they looked at about 183 patients who developed contrast-induced nephropathy, defined as the more than 25% increase in serum creatinine, to at least 2 within 2 days after receiving contrast. And out of their data set, they looked for 174 individuals that were about the same age, same sex, same comorbidities, that were fairly similar, and but they did not develop acute kidney failure or contrast-induced nephropathy. They followed them and they looked what happened to them. So their primary outcome measure was deaths during hospitalization. That's usually defined as 30-day mortality. What did they find? Well, they found, to their surprise, that the individuals who developed renal failure, that is contrast-induced nephropathy, their mortality was a lot higher, even adjusted for all comorbidity, as well as they had a more than 5 times higher risk of dying in the hospital when they developed contrast-induced nephropathy. And remember, those are all individuals that were all hospitalized. Nobody was an outpatient. Yeah. So some were obviously in intensive care units, some were on the regular floor. And here's the clinical course. So here's the pre-existing conditions. About 22% had sepsis, over a third had respiratory failure, so I presume they were on a ventilator. 40% had mental status changes, and 15% had bleeding problems. This was pre-existing before they developed contrast-induced nephropathy. And see, that's what happens afterwards, during their course. Okay, what happened? Each of these conditions essentially doubled, from 22 to 45, from 36 to 78, from 40 to 68, bleeding here from 15 to 27%. What they concluded was that this high mortality of acute renal failure caused by contrast-induced nephropathy is not explained by the underlying condition alone, but the kidney failure appears to increase the risk of developing severe non-renal complication that lead to death and should not be regarded as a treatable complication of serious illness. Very few of these individuals developed significant kidney failure that they needed dialysis, okay? And dialysis is not a specific treatment really for a kidney failure. All it does, it replaces kidney function as long as the kidneys don't function, but they have no effect whether or not the kidneys recover. So, and later studies here published in 2006 shows this. These are a set of cardiology patients who develop contrast-induced nephropathy by the usual definition. And here you see the event-free survival. So they start obviously at 100, and this is months, 1 year. This is the group who did not develop contrast-induced nephropathy, and then here's the group that developed. And you can see survival here's about 90%, and here it's probably somewhere 65%, markedly different, and here significant. So it's not only that there's a short-term increased mortality, but a 1-year mortality risk. And here, mortality in individuals who, another group or a similar group here, where the creatinine or kidney function did not change. Okay? Here it changed up to 10%, really no significant difference. Here the change was about 10 to 25% no. And as soon 25, you see there's a marked increase in mortality, which now makes sense and I'm not sure that was the reason that researcher back some 30 years ago or 40 years ago chose the 25% increase in serum creatinine as definition for contrast-induced nephropathy, because this data was not available when the definition was postulated. Okay. Contrast-induced nephropathy is an acute kidney injury with long-term events, even when renal function returns to baseline. That's important. Okay? And we can talk about at the end why that may be. All right. So now we know about the definition. We know about that it's acutely can cause acute problems and long-term problems. Let's just talk. What are the evidence? How can we prevent it? All right. All right. So does the type of contrast agent play a role? What's the role of hydration? What's the role of so-called N-acetylcysteine, Mucinex, and vasodilators? I told you in the pathophysiology, there's a lot of vasoconstriction. So why don't you use some vasodilator to improve or prevent this condition? All right. So here's a study published about almost 10 years ago. It looked at the various contrast material, iohexol, iodixonol, ipamidol. You can see that in various studies, this is the incidence of contrast-induced nephropathy, anywhere from 10% to 40% here. Those are isoosmol, those are low osmolality. There's really no significant difference. So it doesn't really matter that what kind of agent you use. Okay, there's no clear-cut difference. All right. So that's summarized here that the type of currently used non-ionic contrast materials does not predict the incidence of contrast-induced nephropathy. All right. Let's focus on hydration. Well, we know that dehydration or volume contraction is the major risk factor, although there's never been a randomized trial to compare hydration versus non-hydration. There's a little study done, published some years ago, that looked at elective procedures like, forgot what it was, I think it was CAT scans with contrast, where they looked at whether there's intravenous hydration versus oral hydration is better, but there was no significant difference. Okay. Some years ago, there was question whether hydration with normal saline is better than half normal saline, and normal saline appears to be better, especially in individuals who diabetics, women, patients that receive more than 250 milliliters of contrast. That's usually only given during cardiac catheterizations. All right. And about 20 years now ago, Dr. Solomon, one of my colleagues up in Burlington when he was still in Boston, published a study here where they looked at hydration with normal saline versus hydration plus given mannitol or furosemide. And the idea was that just hydrate these individuals, and then after they get the contrast, then give them furosemide or mannitol to induce a diuresis and flush the dye out. Okay? But what they found really was that the hydration group actually did the best. They only had 11% incidence of contrast-induced nephropathy versus 26% in mannitol and furosemide 46%. This is a meta-analysis. So we know that hydration is good. We know that normal saline seems to be best and not giving any additional diuretic like mannitol or furosemide. Then several years, almost 10 years ago, a group from, I believe, the Mayo Clinic came up with why not using sodium bicarbonate versus sodium chloride. And they could show that it's the first study that the risk here, I'm not sure you can see it, the odds ratio, so the likelihood that bicarbonate is better than saline is 0.1, so that means it's a 90% reduction of risk of developing it compared to normal saline. And these are all elective procedures, these studies, and the summary shows that, yes, there is a risk reduction of 40% when you give sodium bicarbonate versus normal saline. In emergency procedure, the risk reduction seems even more potent, so 90% risk reduction, but it's only 2 studies. Here they look at whether the type of contrast, isoosmol or low osmolality, plays a role. Looks like here the isoosmol substances, no significant difference between saline and bicarbonate. However, in the low osmolality appears to be, again, a 70% risk reduction when you use bicarbonate. However, one has to be careful because often negative studies are not published, called publication bias. And here this shows the summary of published trials, and here you have a 60% reduction in risk favoring bicarbonate. When you then look at data from studies that were not published, but the data made available to these researchers, you can see there was no significant difference. Okay, yeah, the 95% confidence interval crosses 1, which means it means sodium bicarbonate is not better than normal saline. So to summarize this aspect here is that hydration is the simplest, most effective way to prevent contrast-induced nephropathy, with sodium bicarbonate being the preferred solution. However, if you don't have it available, sodium chloride is fine as well. All right. Some years ago, in 2000, I believe, Teppel and researchers actually from Germany came up with the idea to use N-acetylcysteine, which is an antioxidant. I told you there's vasoconstriction and hypoxia, to use that prior to giving contrast. Again, a dramatic reduction, you can see it here, but it's also like a 90% risk reduction compared to not giving N-acetylcysteine. And that's given orally the day before, twice a day, and the day of the procedure. So one the morning of the procedure and then in the evening of the procedure. And you can see here's all these studies. Initially, it's quite significant, and then some studies didn't really show all that much difference. Here is high dose. So instead of giving like 600 milligrams twice a day, these researchers gave 1,200 milligrams twice a day. Here's one, and you can see that there is a suggestion of that high dose N-acetylcysteine may be helpful to prevent contrast-induced nephropathy. But all these studies, if you look at the numbers, are not all that great. At the most, they have like 230 patients, which is not all that much. Here, you can show the overall effect, favors then patients that have a creatinine that's smaller than the medium, so that at low risk. You're above the medium. Again, there's not much difference whether they receive it day prior to the procedure, so that's helpful, versus if they receive it only the day of the procedure, it's not helpful. And here's a follow-up, what happens to these patients in terms of who of these patients needs urgent dialysis. So is the renal failure so severe that they would need dialysis? And you can see in the overall study here, placebo versus N-acetylcysteine, there's not really all that much difference. It's less than 1%. And there's virtually no study who looks at patients who are really at high risk, and that is when the serum creatinine at baseline is 3 or higher. And because of those, you would probably see somewhat more need for dialysis in these patients. The average serum creatinine in most of these studies is usually in the high 1 range or low 2 range. And then if you compare N-acetylcysteine versus placebo in terms of death, that's 30-day hospital, usually non-fatal myocardial infarction and cardiac patient, there's no difference. Need for dialysis, again, no difference. And need for repeat hospitalization, again, there's no difference. So that summarize that high-dose N-acetylcysteine may reduce the risk for contrast-induced nephropathy, and that's a dose of greater than 1,200 milligrams per day. And until about 2 years ago, so N-acetylcysteine was given. It's cheap, has no side effects, but we weren't really sure whether it's really helpful. And this is now a large study done by cardiologists in Brazil. They gave high-dose acetylcysteine for 2 days. They defined contrast-induced nephropathy, the usual more than 25% increase of serum creatinine above baseline between 48 to 69 hours after angiography. There are more than 2,300 patients in that either had one risk factors for contrast-induced nephropathy. They were older, they had already renal failure, diabetes, congestive heart failure, or hypotension. What did they find? Well, they found that the incidence of contrast-induced nephropathy in the acetylcysteine and the control group were essentially identical, that the combined endpoint of mortality or need to dialyze at 30 days was the same, 2.2 versus 2.3. So their conclusion was that acetylcysteine does not really reduce the risk for contrast-induced nephropathy and other clinical relevant outcomes in high-risk patients. So that most centers, as far as I can tell, are not using it anymore or not that often. So here's a summary of vasodilators to prevent contrast-induced nephropathy. Atrial natriuretic hormone, one dopamine. We used to use that in acute kidney failure of sepsis. An endothelium antagonist. Endothelium antagonist or endothelium is a very potent vasoconstrictor. So the idea was that the antagonist would improve it. However, it worsened. The first two had no benefit. Adenosine antagonist, also no benefit. Calcium channel blockers were not really well studied. Indolopam, no benefit. And acetylcysteine, as I showed you, to some degree, it's also a vasodilator. It showed somewhat mixed benefit. So, contrast-induced nephropathy. So how can we prevent it? All right, so the major keys prevent volume contraction, or what layperson call dehydration. So it's probably a good idea if patients are on diuretic, they take non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, Celebrex, and so on, to hold that and then medication like ACE inhibitor or angiotensin receptor blocker that many patients, diabetics, get for hypertension, or patient with heart failure for their heart failure, okay? So that you hold them the day of the procedure. You make sure they're well hydrated, and they're not, you give IV, you can use sodium bicarbonate, and there's many hospitals, there's certain protocols based on these studies. You give certain amount up front, which is higher dose, and then you give it during and after the procedure for up to 6 hours, which is often only practical, obviously, for inpatients. Difficult to do that in outpatient. For the radiologist or the cardiologist to do the procedure, it's important to minimize contrast volume, use the low or isoosmol agent, and may use high-dose N-acetylcysteine together with hydration in high-risk patients. Good. So then I have a couple slides on individuals, since we always get asked, who are on dialysis. Okay? So individuals on dialysis obviously have no meaningful kidney function. They still may make some urine, but for the most part, their kidneys are gone. That's why they're on dialysis, and hopefully eventually will receive a transplant if appropriate. Okay? Now, both hemodialysis and peritoneal dialysis remove iodinated contrast. They also remove gadolinium, which is used in MRIs. Effectiveness depends obviously on blood flow, dialysis membrane, and a variety of other issues. Hemodialysis removes the dye fairly effective in 1 or 2 sessions, where peritoneal dialysis it takes up to 3 weeks. Well, is that dangerous if the dye stays in? Well, not really. It's only dangerous if the cardiologist especially gives more than 200 or even 300 milliliter of contrast, because the contrast, especially the low osmolality, the osmolality is still higher than the serum. So it sits there, and it's an osmotic active substances, and it can draw fluid from the cells in interstitial space and then can cause pulmonary edema. Okay? So in dialysis, patients avoid osmotic fluid overload, meaning by not giving too much contrast material. We always get asked, they need dialysis right away, and the answer is no, they don't need it. They can sit there for a day and we dialyze in the next day. So an extra hemodialysis session for removal of contrast is unnecessary. That's in contrast to gadolinium. Now, gadolinium doesn't cause contrast-induced nephropathy, but it causes a skin condition similar to scleroderma called nephrogenic fibrosing nephropathy, or dermopathy, sorry. And that if patient really needs MRI with gadolinium that is on dialysis, they need 3 consecutive days of dialysis to remove, based on one study, about 95% of the gadolinium dose. That's it. Thank you very much for your attention. I'm looking forward to answer some questions.
Great. I'm looking at the question chat box. So we also, here at Northwestern, we do the bicarb. We actually have a pretty nice protocol with our CT department. We don't necessarily prepare a patient for MRI. MRI's cutoff is their cutoff, and they won't agree to the prep. Do you see that with you know, that sort of a trend with some departments, gadolinium versus your CT contrast?
That you mean that they don't give gadolinium at all in advanced kidney failure or dialysis patients?
Well, no, that they don't agree. They don't agree that hydration with bicarb would make a difference for MRI, or that should be done.
No, not for MRI. No,
Yeah.
that's right. That's right. There's no.
Yeah.
That's not. That's a totally separate topic, right?
That's interesting to me.
Gadolinium is primarily or has been a problem for patients who are on dialysis or already have advanced kidney failure or some that had acute kidney failure. Okay, so they've that's for the most part in those situations. If you can avoid it, you don't want to give it to them. And we have, I mean, last year, I believe there was only 1 or 2 patients from our dialysis patients that we had to dialyze who were exposed to gadolinium on an elective basis. We knew about it. And so.
Very interesting. I don't, Ed, do you see any hands raised? I do not. I don't see questions. Do you see any, Ed? Because I don't see those on my side. Here we go. So there's the first question. Does the length in time of hydration?
Yeah. Good question, because sometimes you know, we have to give contrast emergently. Patient has an acute heart attack, and that bicarb protocol that most centers use is they give bicarbonate. The first hour they give about 3 milliliter per kilo body weight per hour. I mean, they would run in 270 kilo patients, so they would run in 200 milliliter of the sodium bicarbonate, and then 70 milliliters per hour for another 3-4 hours. Okay, but if you need to, and the patient look very, you know, volume contracted, you can run in a half liter or a liter of either of sodium bicarbonate or normal saline within 15-30 minutes without any problems. Okay, so as soon as they're hydrated, they're fine. It doesn't matter how long that is. Okay. Yeah, good question. Outpatient prevention. So the most important prevention is that the radiologist or cardiologist know what their serum creatinine is, okay, up front. And if they do, and it is certainly, I mean, nobody really knows, is 1.5 already kind of a cutoff, or is 2 a cutoff, that certainly if they're above 2 baseline, then the first question is that the doctor who ordered it is aware of it. Does they really want it? Sometimes we nephrologists in the hospital get consults to estimate the risk of contrast-induced nephropathy in hospitalized patients, okay? And then we advise patients to hydrate themselves orally, okay, before they come for outpatient procedure. Because more often than not, it's often these patients who are made NPO after midnight, and then they're scheduled for 10 o'clock. And then an emergency comes in and is done first, and then it takes till maybe 3 o'clock in the afternoon till they get their study, and then they're really volume contracted, and then if they have abnormal kidney function, then that's when they develop contrast-induced nephropathy. So to prevent an outpatient, best know the serum creatinine, make the doctor who orders it aware of it, and then tell the patient to hydrate him or herself orally. And then if there's any question, it's obviously the obligation of the radiologist or cardiologist to look at the patient, see is that patient adequately hydrated.
Yeah, I can tell they're working on something there.
Yeah. Now the other, I showed you this marked increase in morbidity and mortality in these patients who develop contrast-induced nephropathy. And remember all these patients, at least in the study, were fairly equal. So in a sense, if you develop contrast-induced nephropathy, it's like a stress test for the kidneys, and it tells the physician who sees these patients that these patients are somewhat intrinsically sicker, despite that they look fairly similar. Okay? All right, we use the GFR for our reference point. At what point would you cancel a procedure in the GFR? These are outpatient elective procedure. All right. All right, so first of all, just that everybody understands it, for now several years, the laboratory tell you estimated glomerular filtration rate when you order serum creatinine. And that's correct if the patient is in a steady state, meaning that the creatinine is stable and doesn't change over, the next day when they have acute kidney failure. So you need to kind of know, is it stable? And that applies presumably for outpatients there. Yeah, we don't have any, certainly probably in the early stage 3, so if your GFR is anywhere between 45 and 60, and it's truly stable and you're well hydrated, your risk is probably minimal, okay? So the risk starts probably if your GFR falls below 45. And again, it's a judgment call. You have to, the ordering physician with the radiologist, and need to discuss that. Is the test really necessary? Do we really need contrast? Because as I said, it's best to avoid or prevent it if possible. And one of the best ways is not to use it at all if there's other imaging modalities available. You experience a bicarb shortage? No, we don't, but I know that nationwide there is a even normal saline shortage. Believe it or not, I was just reading that one company who has plants in Spain was allowed by the FDA to import the saline produced in Spain into the U.S. because we have so much of a shortage. Yes, so obviously, if we don't look for contrast-induced nephropathy, we're never going to find it. So in high-risk patients, certainly I would make sure that at some point, doesn't have to be 48 hours, a week later, that serum creatinine is checked to make sure that the kidney function has remained stable. So patients with multiple myeloma back years ago were, in my training in the 80s, that were at higher risk of developing contrast-induced nephropathy. Many of these patients, however, had high calcium level, and high calcium level leads to inability of the kidneys to concentrate urine. So they're at the verge of dehydration, volume contraction, and that's probably why they develop more contrast-induced nephropathy than other patients. If a myeloma patient is well hydrated, doesn't have hypercalcemia, and does not have substantial kidney failure, it can be safely given. The other one was that individuals that were later diagnosed with what's called cast nephropathy, and where those myeloma casts are damaging the kidneys, also were exposed to dye, but they may have had already some degree of acute kidney failure up front. So as long as they're well hydrated, myeloma patients can receive contrast. Okay. So the protocol for sodium bicarbonate is typically 3 milliliter per kilo the first hour. So if you have a 70-kilo patient, you give 210 milliliter first hour, followed by 1 milliliter per kilo per hour for the next 4 to 6 hours. So that would be the 70-kilo patient, 70 milliliters per hour, at least some 3-4 hours. In the studies, it was up to 6 hours.
And if there aren't any other questions, are there any? If not, we can conclude and then perhaps ask that any future questions certainly can be emailed to us, and we can forward them on to Jim Callan or Dr. Weiss directly to answer future questions. Does that sound reasonable, Dr. Weiss?
Yeah, that sounds fine. Very much.
Great. Well, we've really had a pleasure listening to you today. Thank you, Dr. Weiss. We know that your time is valuable, and we've really appreciated you lecturing this evening.
Yeah, thank you for the opportunity, and thanks Jim Callan, who was instrumental of getting me on board here.
Yeah, he's great. He's very receptive, and we will certainly thank him too. Thank you, Jim. Everybody have a good evening. Any more questions, Ed? And if there aren't any other questions, are there any more questions, Ed? If not, we can conclude.